Thank you. Here we go. You are good.
All right, good evening. Welcome. Happy Walk Week, Angelman families. I am thrilled to be joined tonight by some of our fabulous clinicians. I am Liz Jalazo, the clinical director of the Angelman Syndrome Foundation, also a parent of a child with Angelman syndrome. My 6-year-old Evelyn has Angelman syndrome, for those of you that I don't know. I'm going to start us off by passing it around and letting everyone introduce themselves and tell us who they are, where they can be found. Yeah, we'll go from there and then we'll jump into some questions. So I'm going to start with the top of my screen with Dr. Carson.
Hi, everybody. I'm Rob Carson. I'm a pediatric neurologist, epileptologist, and now direct the Angelman Syndrome Clinic at Vanderbilt in Nashville, Tennessee.
Fabulous. And I remembered the last question I was going to make you answer as you introduced yourself. Tell us about how long you've been seeing Angelman patients.
I think I started when the clinic opened in 2018.
Okay.
So I'm kind of the newbie to the group. So I'm glad I'm on with all these other very smart people.
We're happy to have you. All right, Dr. Ochoa.
Hello, I am Cesar Ochoa-Lubinoff. I am a developmental behavioral pediatrician, and I work with Dr. Lisberry Kravis at Rush in Chicago. We co-direct the Rush Angelman Syndrome Clinic there. And yeah, we have a multidisciplinary clinic. We are also relatively new in the Angelman syndrome world. We became involved with the STARS study, and but we moved forward really quick, and we recruited a lot of patients in the STARS study and the Neptune, and then we started the clinic, and now we are having an active role in the Tangelo and genetics studies. Yeah, we're excited to be here. Thank you.
Fabulous. Thank you for joining us. All right, Dr. Jeste.
Hello, I'm Shefali Jeste. I'm also a pediatric neurologist at UCLA. And I specialize in neurodevelopmental disabilities and actually have been seeing kids with Dup15q syndrome for a very long time. We had a Dup15q clinic, and then recently became one of the 15q clinics, which includes kiddos with Angelman syndrome. We're also actually a site for Tangelo and genetics. And so we've been lucky to be a part of those trials. I am actually moving to CHLA, Children's Hospital LA, in July to be chief of neurology there. And we will be starting a 15q clinic there as well. So there'll be a couple of LA options for those of you who would like to be seen. And I'll just say that we see kids for a range of reasons, but our clinic has definitely sort of really been focused on the behavioral and neurodevelopmental challenges that our kids with Angelman and adults actually face. And so that's sort of an area of focus and expertise that we have at UCLA, and we'll have at CHLA as well. So thanks.
Fabulous. Thank you for joining us. All right, next on my screen is Dr. Thiebert.
Oh, hi, I'm Ron Thiebert. I'm a pediatric neurologist and epileptologist at Mass General in Boston. And we have been seeing kids and adults with Angelman syndrome for 15 years now, so since '06. Yeah, we're also a Tangelo site that's like just starting up. So, but yep.
Exciting times. Thank you for joining us. All right, and last but not least on my screen is Dr. Dewis.
Hi, everyone. I'm Jessica Dewis. I am a pediatric geneticist and also have an appointment in our special care outpatient complex clinic at Children's Hospital Colorado. And we have a multidisciplinary chromosome 15 clinic where we mostly see Angelman kids, but a growing number of duplication 15q syndrome kids.
Fabulous. Awesome. Thank you for joining us. And Dr. Mark Naspeka will also be joining us at some point tonight, so you may see him pop up. He's a neurologist at Rady Children's Hospital in San Diego, so he will join us at some point. our goal for tonight is just to get some questions answered, give a flavor of some of the, what you might find in some of the 15Q clinics, the Angelman clinics around the country. A lot of these questions have been generated by folks in the community. A lot of these are common questions that we hear on a daily basis, weekly basis at the foundation. And so really appreciate you all taking the time tonight to lend your expertise to the communities on our really exciting walk week. So we are going to jump right in. Amanda just put in, for our audience, feel free to put questions in the chat box. She will be manning the chat box, and we've kind of broken up questions by domain. And so we'll kind of stop at the end of each section and see if there's questions from the audience that need to be answered. So I'm going to jump right in, and I'm going to start with Dr. Dewis. So why might a patient seek care at an Angelman clinic, and what can they expect from a visit to one of the Angelman clinic sites?
Well, I think there are various reasons why someone might come to the clinic. One might be is that it's just the local providers for them to come get specific Angelman care. Other reasons could be just having some difficulty managing any of the specific symptoms of Angelman and want to do a consultation to help with management. I think all the clinics are pretty different, so I'll speak about our clinic at Children's Hospital Colorado. We're very management focused, and so we have several focuses that we our providers look at. So seizure, sleep, behavior, and gait are big ones. So mobility in general. And then we also have an AAC specialist, so looking at communication devices. So I think if you need any one of those specialized pieces of care from someone that's very familiar with Angelman syndrome, that's a good reason to come to the clinics. A day at our clinic, it takes about 4 hours, and it's a whirlwind. You kind of sit in the same room and we all rotate through one by one. I should also mention we have a dietitian and focus our care also on individuals interested in diet, so we can help get people on specialized diet like low glycemic or ketogenic diet. So we just all rotate through, so pediatric neurology, complex care / genetics, rehab medicine, developmental medicine, OT, PT, speech, and a dietitian, and we just kind of all rotate through and see you and try to focus most of your time on the areas that you're most concerned about.
Fabulous, thank you. And I should say, I'm going to lob these questions at an individual, but everybody is welcome to chime in if there's a different flavor at your clinic or anything that you want to add to any of these questions.
One thing I would just add is that I think, yeah, every clinic is a little bit different, but we also as a clinics group meet once a month. And I think that's pretty important because it allows for us to, get advice from each other, share kind of clinical insights that we might gain, get expertise from others who may have more expertise in certain areas. Like Ron has, I think, managed more epilepsy and Angelman than probably all of us put together. And so it's helpful sometimes if I'm managing a complex epilepsy case to talk to him. And so I think that's something that also is pretty unique to the AS clinics.
Here's a good question. We'll go live here. Do you find that local doctors actually contact AS clinic doctors for consults? It's a great question. Has anybody been contacted by local doctors for care? I know, Dr. Thiebert, I've connected you to several other local providers.
Yeah, I think that with local doctors, it's it can be hit or miss. Some aren't super interested in contacting or being contacted, but some are very open to it. And when they are, it's just really helpful because then we can. Especially if it's someone we haven't seen in a long time or maybe even haven't seen, we can give advice through the doctor. We can't really give advice to people we haven't met yet, but it's a nice way where local doctors that have, specific questions can, check in. And then, when we kind of just talk doctor to doctor, it's something that we can really be helpful with from afar.
Ron, I'll throw this question back at you. Do international doctors ever contact the clinics for advice?
Yeah, sometimes. Not super often, but sometimes they do. And same thing if, you know, we can't really offer much to families we haven't met, but if a doctor contacts us with specific questions, then, you know, we can talk with them and you know, give advice, and then they can take that advice and use it to make any changes they think they need to make.
Yeah. And I should highlight, you know, tonight we have largely representation from the US clinic sites, but there are some international clinic sites as well that are seeing a lot of patients with Angelman syndrome and really providing expert care, who do participate in the monthly clinic calls and are really contributing significantly to the clinical care of patients with Angelman syndrome across the globe. So this is a service that we often provide. We're often hearing from providers or international families who would like to be connected with a provider locally here. All right, this is a loaded question that we're hearing a lot of right now. So Dr. Carson, if a patient lives out of state, can an AS clinic be their primary neurologist?
So yes, I'll just say it that way. You know, we have a lot of patients just even within our regular neurology clinic as well as the Angelman clinic. You know, in Tennessee, it's kind of a long, skinny state. So we definitely have patients from Kentucky, Alabama, Mississippi, kind of all the contiguous states. The only curveball you know, one of the nice things, if you can say anything nice about COVID, is that it has really pushed telehealth to become a reality. Now the reality is, though, we can only do telehealth in states that we have a license. So that is somewhat limiting, but one of the things that I'm hoping to do is try to use a consortium to pick up licenses in those contiguous states. So we can still hopefully then use telehealth to, you know, at least be able to meet and talk to families who can't make it to the clinic or just can't make it back for a follow-up.
That's great. I know this is something that several clinicians within the network are interested in doing. And so this is something that I hope in the future Zoe will be able to help guide families. So if they would like to see an AS clinician, being able to reach out and figure out which clinicians might be licensed in their state to be able to do telehealth versus, you know, be able to see them in person. And I think for the most part, any clinic can see anyone in person. It's really more of an issue with telehealth right now, correct?
Yep.
Yeah.
Hey Liz, really quick, a question came through the question box. Can they do online consultations for patients outside of the US?
Anybody want to tackle that?
I've done
Anybody?
those, and we just work through our international office. Most universities will have that, and they can work with the family to arrange for that. So it's definitely feasible.
Great.
The additional point I want to make about that, though, is just I think that there's a lot of value in coming to the expert clinics, and so I highly endorse that. But it is also it's pretty important to have someone local, especially if you have really active neurological issues like active epilepsy that needs to be managed. So what we try to sometimes do, or often do, is, you know, we can be the consultants and we can help guide care, but that we then will help communicate, you know, we'll communicate with the primary neurologist who's local, so that if there's any emergency situations that come up, there's someone nearby who can help. And I think that's important to have.
I also know many states Medicaids require an in-state provider to be writing the medications. And so having that partnership between the expert in the Angelman clinic and the local provider can be really beneficial. Great. Anybody else with anything to add on that before we pivot to another topic here?
We've seen several international patients, so it like Shefali was saying, with the through the international office, it's definitely doable. It's just that, you know, the travel's never easy, but
Great.
But it can be done. Yeah.
Great. That's good. And maybe that's something that we should have a formalized pathway to be able to help facilitate that through the international offices at a couple of these larger hospitals. All right, Dr. Ochoa, if a patient is interested in getting involved in research through one of the clinics, what's the best way for them to do that? Oh, you're on mute.
Families can contact the program directly. We have a number for the clinic, and our clinic coordinator works in the next to the research coordinator. So we can give information about the clinical trials, and we can put them in the waiting list. Now we have some waiting lists for the different clinical trials we're participating, but everybody's encouraged to get in the list and learn more about, and we are ready to give that information.
Fabulous. Dr. Dewis, how can patients expect to keep up to speed with what clinical trials might be happening through the clinics?
I think being in touch with the foundations and the Angelman Syndrome Foundation and Foundation for Angelman Syndrome Therapeutics can be really helpful. And there's often updates coming from companies that can help you know where things are with recruitment. I think also all the companies have done a really good job with having phone lines available and having phone numbers to contact them, asking about clinical trials. And then, of course, I think it's always good if you're coming to a clinic to ask those questions when you're here about what's open and available, or what it looks like to be a part of the clinical trial if there's interest.
Yeah, who really should be part of that team that's helping families decide? How do families decide if participating in a clinical trial is right for them?
I think it's in part talking with the clinicians that you're seeing, whether they be your local clinicians or someone that knows your child, and also being in touch with people who know what you're getting into when you're doing the trial, what that study visits look like if you have to travel. And then, I think in some ways the clinical trials choose the individuals who participate just based on, geographic location, but then also specific subtypes of Angelman may fit better into certain or different trials. So being in touch with your clinicians and having an ongoing conversation about what's available and what they feel like is appropriate for that individual.
Awesome, thanks. I think for each of our clinic sites, there should be as Dr. Ochoa mentioned, either research coordinator contacts or, clinical scheduling contacts that can help, know what's available at each clinic site. All right, Dr. Jeste, why is collecting data through the clinics important, and what is this ladder database that people might have heard about?
The famous ladder database is pretty amazing and awesome, and something that I think a lot of different rare disorders are trying to emulate right now. So, here's the thing, like we as clinicians and you as parents know what Angelman looks like, right? But many of us know it in the context of one child or a few children, right? And what we really want to do is try to understand, what does Angelman look like across the whole spectrum? What's the range of challenges these kids have? What are the range of abilities? When we do standardized testing for things like cognition or development, what kinds of scores do these kids get? We need to get data in those big numbers. And the reason is that it helps us not just understand Angelman more wholly, but as we design these trials and have therapeutics that are targeting various aspects of development, then we know what we want to target, but also what are we going to measure to determine whether the treatment's working. We call those clinical endpoints. And so, we can't define clinical endpoints without a lot of data. And the best way to get data actually is through the clinics, because kids are already coming to clinics and getting assessed in different ways. And so through those kinds of clinical databases, we've learned that sleep, for instance, is a big issue, and we know that, motor skills are challenged and things like that. And so these big data registries are critical to really push clinical trials forward. And again, from a clinical standpoint, to help us manage kids, because we know what the range of needs are. And it seems like an easier feat than it actually is. I'll say the latter database has been, Liz is smiling because she's been at this for I don't know how long, but it takes a village to build these databases. And it takes all of you guys who are listening on the call, to contribute your data, which is invaluable. But it's a lot of work, but the end result is, I think, incredibly, incredibly informative.
Awesome. Thank you for that overview. And yes, I was smiling because this has been years of blood, sweat, and tears going into designing the right database. But There will be more information that the community will see next week about this big push to get families to enroll. And I think the other big thing that I would highlight in it is that, the goal in this is to reduce parent burden. And we know that you're already filling out hours worth of forms to go to clinics to inform the best clinical care. And so this is about capturing that data, being able to utilize that for drug development, being able to utilize that for, answering clinical questions, answering research questions, and really, making sure that we're able to best care for children and adults with Angelman syndrome and develop therapeutics that are appropriate for children and adults with Angelman syndrome. So really critically important. All right, Amanda, any other questions that are pressing that we should tackle before we move on to seizures?
No, I think we're good. I'm sure we'll get a lot with seizures. Let's move forward.
Okay. All right. I'm trying to keep us on track here. So, all right, Dr. Thiebert, a primary concern for nearly all of our families is seizures. Can you talk a little bit about how seizures in Angelman typically present, maybe for a newly diagnosed family that's kind of waiting for that other shoe to drop or worried about this, and what parents should do if they think their child is having seizures?
That should be a nice quick answer. A lot of it depends on the type of Angelman. So kids with deletions, almost, not all, but almost all of them will have seizures at some point, over 90%, whereas the milder types like UPD or UBE3A, it's more like 2/3 to 3/4. For imprinting center, it could be even less than half, possibly. So that's one thing to think about. And then, for the kids with deletions, it's the most common. So for them, seizures often begin by age 3. So it's kind of those early years. And the seizures most often begin with fever. So the little person will get sick, and then they spike a fever, and then you might see that first seizure. The first seizures are typically not the big kind of shaking ones that we're used to, what we call tonic-clonic, so kind of eyes back, everything shaking. The most common seizure types are usually start off with our drop seizures or head drops. We call them atonic seizures, where like the head will drop or the body will drop. Sometimes it's easy to like have a kid who's sleepy and just kind of like nodding off, and it looks kind of seizures. But if they're really seizures, you'll know they're very impressive, and they usually come in clusters. You can have what we call absent seizures, where it's mainly a staring spell. But if it's a couple seconds where they're seem like they're not paying attention, you snap their fingers, they turn around. That's just them being little kids and not paying attention. So that's a little tricky too. But these seizures typically will go on 10, 20, 30, 40 seconds with just not really quite picking up. And then the other kind that sometimes we'll see before the big shaking seizures is called myoclonic seizures. And it's kind of a quick twitch. Like if you're like listening to this now and falling asleep and your head kind of snaps back up, that's a myoclonic jerk, and we all do it when we sleep. And that's totally normal. But if someone does it and has a big one while they're wide awake, that's more concerning for a myoclonic seizure. So those are the most common seizure types. To start, they're typically seen before a kind of a big shaking seizure. And if you think that there are seizures, then ideally it's not always easy, but if you can record it, that's by far the best thing. If we can actually see a video, it's not 100%, but we can get a really good idea of whether they're concerning or not. And then if there is concern that they might be seizures, then we would get an EEG. But if there's just a few little head drops or a couple staring spells, you don't have to go straight to the ER unless it's in the setting of fever, and then it might be good to go just because of the fever. You don't know how like significant infection it might be, but definitely check in with your doctor, and video is great. But even if you don't have video, just kind of calling in and just kind of letting them know what you saw, what it looks like. And another kind of good thing to think about too, if you're worried about seizures, if kids are just acting like themselves and moving along and making great progress and looking otherwise totally great, that it could be seizure, but it's less likely, as opposed to if it's been a week or two of maybe not being as alert, not getting some reports from school that they're not quite doing as well at school, and then you see these events, that's a little more concerning that they might be seizures. So, but anything worrisome, definitely give your doctor a call or send a video, and then go from there. Unless it's a big shaking seizure, you typically don't have to go to an ER right away if you're concerned about seizures. But definitely let your doctor know if you're worried.
Awesome. I really like that advice to just capture it on video and have somebody take a look at it. I think that that's really important. I think oftentimes, understandably, it feels really panic inducing to be worried that your child is having their first seizure, and the first inclination is to feel like you need to run to the emergency room, but I think that's fabulous advice. Dr. Carson, what is status and what could that look like? What should parents look out for? And if they think their child is in non-convulsive status, what should they do?
Call Ron. He may be able to weigh in on this better than I can, but I think if there's definitely a change where someone is just not acting right, and with non-convulsive, so convulsive status, there's different functional definitions that are used for different purposes, but really it's just a prolonged seizure. We often use the magic number for a convulsive seizure of 5 minutes as really of saying, if a seizure lasts 5 minutes, we should probably treat it with something like diastat, because it could last 20 minutes or it could last an hour. And those are the seizures we really, really don't like. So convulsive status can rapidly become it is a medical emergency. Non-convulsive status is exactly that. It's non-convulsive. So it can be a little more tricky to identify because sometimes, I'm using nebulous terms like your child is just not right. And so and I think that's it's a good question of how do we tell from just general tiredness. Ron, I don't know if you want to jump in at this point.
Yeah. Oh no, that all sounds exactly. That sounds great. But yeah, it's probably the toughest thing with non-convulsive status is when kids get sick, because when they're sick, they're going to look kind of out of it and not quite right. And then the big question is, at what point do you say, well, they should be feeling better by now, and they're not, and then that illness just kind of turns into non-convulsive status, and it's never easy. Like kids that have gone into it once, you kind of know what it looks like, and then when it happens again, it's for that particular kid, it's you can just kind of recognize it and treat it. But if it's the first time, we usually like to get an EEG, and that will that will really kind of tell you whether or not it's status or if it's just they're just not quite right. But it's sometimes it's just not easy. If they're really sleeping poorly, they can look off. If they're sick, they can look off. So it's not always obvious. So whenever families call and say, things aren't quite right, we're worried about status, we always ask, how's the sleep? How's how are GI issues? Because if there's other medical stuff going on, they just might not look like themselves because they're sleeping 4 hours a night instead of 8, and they're not in non-convulsive status, they're just really sleep deprived. So we, a lot of times what we'll do is we treat, if they're in non-convulsive status, we'll use a medicine like Valium in a bigger dose and tapering it down. But if there's also kind of poor sleep involved, you're not sure which one it is, the Valium will actually help both. So even if it's poor sleep, it's, they're going to sleep better with it. So it's always that tricky, is it worth trying to get a stat EEG and have them go to the ER or whatever, or do we just, kind of try some Valium and see if they get better? Kind of the better we get to know somebody, the easier we can make that decision. So like someone we just met, sometimes it can be a little trickier where someone we've known for a few years, we just know when they start to look, however, that's what's going on. But it's a really good question. It's not always obvious. It's something you always have to think about, but if kids are sick, if they're sleep deprived, which is not at all uncommon with Angelman, that's it's trying to figure out which one it is. Sometimes it's not easy, but luckily, the same medicine can help both sometimes. So we may just treat with that, and if it was just bad sleep, the Valium will help the sleep, and then kind of resets the cycle.
Yeah, what I'm hearing is really reassuring that it is treatable. And so, whether we can definitively prove whether a child is in non-convulsive status or whether it gets better just with the treatment, either way, it's treatable most of the time with a reasonable fix.
Yep.
All right, Dr. Dewis, can you talk a little bit about diets for management of seizures and how they can be helpful in Angelman syndrome?
Sure. So the traditional way of thinking about diet, and I'm happy for anybody to jump in as well, is that if you're having difficulty controlling seizures with more than 2 seizure medications, then thinking about ketogenic diet for seizure control can be really helpful and help get your child off of multiple medications. And the true ketogenic diet is a very carb restricted diet, very strict diet with high fat. Nowadays, we often use low glycemic index therapy, which is a less strict version of the ketogenic diet, in which we focus mainly on carbohydrates that are not going to increase blood sugar significantly when they're taken in. So there are different levels of glycemic indices for different carbohydrates, and we generally like them less than 50 for low glycemic index diets. And we've been using those in our clinic for a while, just in general. When kids get diagnosed with Angelman, we offer it to all families. We haven't published anything, but we do think that there are benefits beyond early seizure control, where we're not having to use more than 1 or so medications for management of seizures along with the low glycemic index therapy. And we also think that we're seeing some differences in the developmental trajectory of kids. Like I said, we haven't systematically studied it. It's only anecdotal, but I can say definitely that we feel like we're seeing a difference. And so we do in our clinic tend to promote utilization of at least low glycemic index therapy and then tightening control if we think it will help with seizures. And that tightening control would be more towards a strict ketogenic diet.
This is gaining a lot of popularity in the community. Most families have at least heard about LGIT diet or other diet options, and a lot of families are talking to one another about it. If families are interested in learning more about diet, where can they learn more about diet?
Certainly reaching out to any of the clinics, I think would be a great resource. We're happy if you reach out to us. We've developed a handout that we provide to all families that has multiple different sections, including things like eating out keto and things like recipes, but also has just general instructions, step-by-step, how do you get onto a LGIT diet, how do you get onto a ketogenic diet. And that's something we'd be happy to share with the Angelman Syndrome Foundation so they can put it out to the community.
Dr. Thiebert, did you have something to add?
Oh, yeah. As far as just resources, one of the best, if you just want to know what dietary therapy is, and one of the best resources is the Charlie Foundation website. It's one of the guys that wrote the movies Airplane and Naked Gun and all those classics. His son had really bad epilepsy many years ago, and it wasn't until they went somewhere where they offered the diet and then they tried it, and then his seizure stopped. So that's been his kind of his big cause, which is great. But they just have a lot of good, just basic information on diet therapy. Not Angelman specific, but if you're just kind of curious on what being on the diet entails, that's a good start. And then definitely, contacting a clinic for more information if you're, thinking about getting started on it.
Great, fabulous. All right, we got a couple of questions here. So if we've gone to, all right, Dr. Jeste, jump off whenever you need to. Thank you for joining us. If we have taken a patient all the way to strict keto, how long would we recommend staying on strict keto? Do they stay on strict keto forever, or is there a step back to LGIT, or how does that work?
They can be on keto for however long. When a study that actually came out of Mass General, not for Angelman, but they showed really good safety data, 10 years out. Most kids we see that I think we've probably seen something ridiculous, like 100 kids for diet consults. And unless they're infants or have a G-tube, the low glycemic is just a lot easier. So we generally start with that and then kind of convert to keto if needed versus the other way around. But we find that a lot of kids with Angelman syndrome tend to respond kind of better at even higher carbs, even, that typically it's 40 to 60, but sometimes even 60 to 80, as opposed to kids without Angelman syndrome with epilepsy. We don't know why specifically, but there's definitely some thoughts, but just kind of in practice, having seen so many kids, a lot of times we'll start someone on the real strict on the diet, and then as time goes on, they're doing well, they'll kind of maybe intentionally, not intentionally, kind of loosen it up a little bit and add a little more carbs. And then we find out that, they're really more like 80 to 100 and they're still not having seizures. So the kind of the proper amount of carbs really is the one that you're still seizure free on. But like Jessica was saying, we, again, we haven't, it's hard to quantify, but just what we see in clinic is kids that start the diet early, they tend to just do better developmentally.
I appreciate that comment. So another common issue that comes up is lab monitoring for kids on diet. Can somebody speak to the need for lab monitoring? I think in the community, there's a little confusion about whether kids need to be monitored by a nutritionist or why that's important.
Oh, sure. Yeah, it's definitely important. Kind of the stricter you are, whether it's, the 40 to 60 and then as you get kind of more towards keto, it's even just more and more important. There's just, there's things that even though there's way fewer side effects with dietary therapy than with medicines, there's still some potential side effects. Your blood can be a bit more acidotic than it should be, so a little more acid versus base, just because of all the ketones you're producing. You can have a decrease in certain things that are helpful for just general functioning, like vitamin D, carnitine. So it's important to check those labs we start off every 3 months, but if kids are doing really well and they're super stable, the labs have been good, we'll kind of space them out a little bit. But really every 3 to 6 months for kids on low glycemic, just because, even though they may not be, significant changes, even little changes over time, can have some unwanted side effects. So it's really important to and keep an eye on that. It's also important to keep an eye on height and weight. Sometimes you're eating a higher fat diet, kids will get full a little sooner, and so they might not eat as much, and then we notice they start to lose weight. And weight loss is definitely not good for seizures or anything else. But I mean, if you're a healthy weight loss isn't good. We really try. I know there's always questions about the diet, whether kids are too skinny or a little bit on the bigger side. But even though they call it a diet, it's not a weight loss thing. If kids are a little bit heavier than they should be, the diet will be tailored towards kind of losing a little bit of weight. If they're a little skinnier than they should be, it'll be kind of tailored towards kind of adding a few pounds. If they're at a healthy height and weight to start with, then the goal is just to kind of keep them there.
Thank you. That's helpful.
I did want to emphasize the importance of getting some labs when you're first going on diet, even the low glycemic index, because we have seen kids with Angelman seem to be a little bit more prone to fasting ketosis. We saw this with the clinical trial, and we're seeing it clinically too, that we don't know why, but it may be that their metabolism is just a little bit higher, but that susceptibility to fasting ketosis does put them at higher risk of getting that acid buildup in the blood. And so monitoring that can also help tailor the diet so that you're on that right number of carbs to prevent that complication. Very rarely, especially on stricter diets, though, we even need to start medications to prevent that acid buildup in the blood. And just the other things, just going back to the long-term use of ketogenic diet, there's a couple of other additional things you might monitor, like calcium and bone health, that we just want to make sure that we're keeping a close eye on with diet.
Awesome. And you guys have alluded to this a little bit. So, perhaps, obviously none of this has been rigorously studied, but, is anybody anybody want to wager things that they feel like anecdotally are improved on diet, or other things that diet can help with?
I would say just, we just see, and again, that's why it's hard to measure, but it's kids just seem to be overall a little bit more alert, a little more focused. That's actually a big, even kids without Angelman syndrome, we notice better focus because you're not eating a bunch of sugar, getting that rush and then crashing. So like that's a big thing is focus, and that's not even Angelman specific, but that's more what we see is focus and attention, and then it just leads to kind of more improvement with therapies, better performance in the classroom, and just overall, kids just seem to just do a little bit better overall developmentally, but a lot of it's it really just kind of less focus and alertness related. They're just more, they kind of seem more open to learning, whether we're imagining or not. But I think there definitely is something to it, and it's that lack of the sugar rush and the crash is a big piece of it for sure.
I think you're onto something. I think we'd probably all feel better if we were on a
low carbohydrate and has these sugar rushes and crashes. I can second that. Yeah.
Okay. All right. Let's keep moving here. I'll keep us on track. There are some very specific questions in the chats, and I promise I will get these questions answered, but maybe offline. All right. So we're going to cruise into GI issues. So I'm just going to open it up here. Best tips for managing constipation. Specifically, the community has asked, is Miralax okay to use, or are there other more natural remedies that can be beneficial? Anybody?
A good question. Miralax can definitely be used. It's it's often one of the first things people, ideally the number one thing is increase fluids, but there's a lot of kids that just don't like to drink, and it's hard to, you can try to force them, but these kids can be stubborn and do what they want to do. So sometimes that's just hard. But apart from just really making sure they drink enough. Also, there's certain dietary foods that are healthy that can help with constipation. Avocado, coconut oil, these are kind of like high protein fat foods that also help kind of move things through, which is nice. If you're not on a low glycemic kind of diet, things like prunes can help. But if just kind of increasing fluid intake and altering the diet a little bit isn't helpful enough, then Miralax is a good option. And it's a little bit messy it's one of those medicines you can overshoot a little bit and it gets too loose, and then you back down and you get a little bit constipated. But beyond that, before getting to like kind of hardcore GI meds, like senna is something that's really it's a plant extract that's over the counter, but comes in pills, but also a tea that a lot of people seem to like, a senna tea. But those are before moving into more like hardcore GI type medicines, those are a couple of easy over the counter solutions if just fluid intake and dietary therapy aren't enough, which they often aren't. It's just their GI systems just aren't built for kind of quick transit. So constipation is really common.
I would just add magnesium can be also really helpful, which is natural over the counter.
Yep.
Do you have a favorite formulation of mag?
I like something called oxy powder, which I'm sure some people in the audience might be laughing about that, but it comes in capsules and you can open them. You can definitely overshoot with it, which is why I'm saying people might be laughing, but it does really work if you need something that's very safe.
And another one that our GI folks like is Natural Calm. It's just
which is magnesium
powder.
Right. Yeah. Dr. Carson, did you have something to add?
Yeah, I mean, there's a bazillion forms. I think some like magnesium citrate has one of the best bioavailabilities versus things like magnesium oxide, all of which though are really, available over the counter, relatively inexpensive. And, the first kind of key side effect you might see is GI and diarrhea. So it's same thing with Miralax. Sometimes it's an issue of just kind of dialing it in and having a stable regimen.
Having just come off a week go ahead.
I would just add a couple of things, like some general thing about trying to increase the fiber content in diet, like try to give foods that have higher fiber content, which is not always easy. Like Metamucil has some wafers that some kids may like, most not. but if they like it, it can be helpful. Benefiber is another source of fiber that can be efficient. And activity, trying to push this, which again is not always easy, and so, but that's something that can help also with the constipation.
Awesome. Great tips. All right, let's pivot into some behavioral issues, Dr. Ochoa. So best tips for managing the sleep issues in Angelman syndrome.
That's not an easy. Yeah, trying to do like behavioral interventions is the first line, right? We always want to do a sleep hygiene, having a bedtime routine, trying to avoid the screens before bedtime, trying not to entertain them as much when there are nighttime awakenings. I think those are like the basic stuff that we want to deal with. But then if oftentimes that's not enough, and the first line of intervention that is outside of sleep hygiene interventions is melatonin. We all produce our own melatonin, and it has a role in regulating sleep. And there are many studies that have shown that using melatonin can be really helpful for individuals with Angelman syndrome. And particularly it helps with sleep initiation, which is oftentimes the most common. Sometimes it can be used for nighttime awakenings, like if they are not waking up too late at night or too early in the morning, you can do a little bit of melatonin to help them go back to sleep if they tend to stay for a while. And then you can, titrate the dose, and sometimes there are different formulations for melatonin that work better for some individuals, but many times, the nighttime awakenings are not going to respond to melatonin, and in those cases, you may need to start thinking about other pharmacological interventions for sleep. We sometimes use clonidine. Clonidine helps with the sleep initiation, and sometimes it can also help with sleep maintenance. But if clonidine is not effective, then you can move up to trazodone. Sometimes we use Seroquel. Trazodone tends to be very effective and sometimes can have, a positive effect during daytime with behavior and regulation. Yeah.
Great. We could spend a whole hour talking about sleep, I'm sure.
Yeah. Yeah. No, I think one of the first points was really one of the most important is that, we always start with behavioral interventions and sleep hygiene, and that's super important. But there's some kids that, if it doesn't work, it doesn't mean you're doing it wrong. It's just some kids just fight through it. And if their sleep is bad enough, those typical things that, pediatricians will recommend for typically developing kids, sometimes it just doesn't work. But I think that's always important to keep in mind. If you've really been trying and it's not working, it's probably not that you're not doing it right. It's just that they just need more. And the other thing with sleep that we always think about is GI. If kids are refluxing or if they're constipated, that can keep them up at night. So that, when we start talking about the sleep hygiene and everything before meds, we'll just kind of check in with that. If they're waking up coughing or gagging or anything like that, then they could be refluxing at night. That's making sleep harder.
I'll add that I think, as Ron kind of pointed out before, we do use a lot of benzodiazepines as treatment for epilepsy, and Klonopin is also one of its biggest side effects is sedation. So a little extra at bedtime can be helpful. And then I don't know if Jess wants to talk about, identifying mirtazapine, which is a medicine that's used also for behavior and mood, and at least in the patients we looked at was really quite effective at getting people to sleep and helping them stay asleep, with the biggest limitation that some kids became extra hungry. And so for some patients, weight gain could be a problem.
Yep. The psychiatrist that we work with uses that medicine quite a bit, and it can be really helpful for sleep, and then also have the added benefit of some anxiety. It's kind of less helpful for the UPD kids who are usually very hungry anyway. But for for kids with deletions that are usually on the smaller side, sometimes the extra appetite can be a benefit. But yeah, that's one that's really, especially for the teens and we have had some younger kids on it, but when anxiety really ramps up after puberty, that can be a really nice 2-for-1 sleep and anxiety medicine.
And I'll just add, some of the families that use it have used it almost, instead of dosing it every night, they've dosed it every couple of nights, because it is a really long acting medication and they feel like they've still seen benefit using it less frequently than every single night. So that's just something to keep in mind too.
Perfect. Well, you guys are segueing nicely for me. We were going into anxiety next. So, Dr. Dewis, what are some signs that a child with Angelman syndrome might be anxious? How does anxiety, or how can anxiety present in a child with limited communication like Angelman syndrome?
Yeah, this is a tough question. The reality is we don't actually know. We think we're seeing anxiety, and we're calling certain behaviors anxiety, but of course we don't know for sure. One of the biggest ones I would say that we see is separation anxiety from a parent, and that can kind of show up in different ways. There's pinching, hair pulling, changes in behavior. And in some kids, we also kind of see them shut down and withdraw, not want to do anything, not want to get up from where they are. I think the main thing to be watching for anxiety is any major change in behavior can be related to anxiety. So always having that kind of in the back of your mind, if you're seeing changes in behavior, particularly kind of aggressive behaviors. I think sometimes when people see that, their go-to thought is that it's not anxiety, but in Angelman, we have seen, instead of going to medications more targeted at aggressive behavior, getting anxiety under control really gets those behaviors under control as well.
It's really helpful.
Yeah, I agree that the presentation for behavior and emotional regulation and anxiety, they all seem to come together, and it's really hard. There's no way for sure to tease them out, but the variation, particularly when they are exposed to some situations like new situations, transitions are particularly hard for our patients with Angelman syndrome. Exposure to unfamiliar people, some sounds, and then you can see some signs that look like anxiety, like tensing their body, but sometimes they are more like behavioral, like they are biting her hands, or they are having other, like they are screaming. You start seeing a little more the externalizing symptoms like hitting, or sometimes engaging in self-injury behavior, which is, it's hard to see that dysregulation, but I like Dr. Dewis kind of, the variation over a baseline of behavior that seems to be associated with some event around them. That is suggestive of a reaction, like an anxiety and emotional reaction.
Yeah, this is such a challenging area. Any tips for managing anxiety in children with Angelman syndrome or adults with Angelman syndrome?
I would say it's kind of like sleep. You try kind of behavioral measures and kind of like non-medicinal type things, and for a lot of kids it helps, but for some they're just anxious enough that you need to kind of move on to medicine. Yeah, and we even it was hard enough a year and a half ago, but once the pandemic started, that was the most common thing we would hear about people from was always typically seizures, but for the last 16 months it's been anxiety. Really, it's just been through the roof since COVID started. A lot of it was parents working from home, so kids being home with the parents, and then the separation anxiety just went through the roof for so many kids and adults.
Imagine.
I also think it's really important to consider the environmental triggers and where the behaviors are happening. For example, if they're happening at school, especially with the transition back to school with COVID, and it can be helpful to do something called a functional behavioral assessment and just collect some data on when the behaviors are happening, so that you can try to make some behavioral interventions to help the behaviors. The other thing we found that's really helpful. I'd be happy for everybody to chime in what they think too, but is applied behavioral analysis can be really helpful, because that both targets kind of that functional behavioral assessment and really understanding triggers, but then can also help with caretakers, really consistency between caretakers and managing things the same way, which I find really helpful.
Yeah, I agree with Dr. Thiebert and Dr. Dewis. Like, behavioral interventions, like the basic behavioral interventions, can be really effective, but it's not that easy to do because the intensity, the magnitude of the behavioral and emotional regulation challenges. But going back to the basics, to trying to understand what is triggering and trying to have consistent responses can be really helpful. I still don't understand why in our current society, there's coverage for ASD ABA, but there's no coverage for Angelman Syndrome ABA. And I know that some people give a diagnosis to help access those services, which, not everybody is ready to do. But I think that's something that I think as a group, we should try to advocate. Something we're trying to do at Rush is trying to implement an ABA program targeted to patients with Angelman syndrome and try to collect some data so we can start trying to move the field towards that goal.
Wow, wonderful.
Yeah, we've looked into that too. It's in Massachusetts, for some reason, Rett syndrome qualifies, but other than that, it's just autism, and it's very frustrating. But yeah, I couldn't agree more.
Dr. Nespeka, thank you for joining us. We are just wrapping up, but we're tackling the very prevalent issue of anxiety, and any top tips for helping to manage anxiety in children and adults with Angelman syndrome?
Well, I mean, I've tried BusBar from Ron and his psychiatric colleague's suggestion, and some patients have improved and others haven't had much of a difference, and then they'll go off of it. But in terms of pharmacological intervention, and I don't know of any specific behavioral interventions that I can say are helpful, but if the family has access to a behavior therapist who can come into the home and provide guidance, that I suppose could be helpful, but that's extremely difficult for my patients to access. So,
well, and particularly in these COVID times, that's not been something that's accessible.
I think the only one other thing I thought of, it's not maybe specific for anxiety, would be that communication is a source of frustration, inability. Sorry, back in somewhere. I was just saying that. So, no. Mark, am I back into you? Sorry.
There you go. I think you're good now.
Okay.
There you go.
Just pointing out again, I think all of us can imagine if inability to communicate is a challenge that can lead to frustration and or not knowing what to expect. So really starting early on looking at identifying augmentative ways of communication, I think is going to really pay dividends later on as kids get older.
I love that advice. I think that's the fabulous final piece of advice to leave us on here. I hope that the community has found this helpful. I know that I have, and I hope that this has given a little bit of a flavor of the kind of expertise that can be found within the clinics. I know that it's not always easy to travel to the clinic sites. As Amanda mentioned before, there is the Angelman Family Fund that you can apply for travel funds. But there is a wealth of really fabulous resources within the clinic network, and they can be a fabulous resource to your local team as well. So thank you to all of our clinicians.
Liz, can I jump in really quick? Just
yes,
really quick. A couple of people have asked if this will be recorded and transcribed. The answer is yes. And for some of the questions that were in the chat box that we didn't get answered, we will get answered and get those answers to you.
Yes. Fabulous. And a final plug for the walk. There's still time to register. So anybody who hasn't registered, heroes, you can unite with your heroes and register and walk remotely in your safe local location this weekend. Thank you all. Have a great night.